Our topic today is about the limping child, different causes in pathophysiology, and how to approach the diagnosis of the limping child. Let's start by defining what's limping. And limping in general means asymmetry. Whenever there is asymmetry in one lower limb than the other, there will be limping. And this can be expressed at the level of the joint by asymmetry in the range of motion on one side than the other side. At the level of the bone, there will be deformity in one bone and not present on the other side. If there is pain in one lower limb than the other side, and at the level of the control, in case of neuromuscular disorders, that one side is affected more than the other side, all of these causes will lead to asymmetry, and accordingly there will be limping. So if we want to speak about the pathophysiology of limping, and according to what we knew from the definition, there are three major factors and main factors that may cause the child to limp. First is pain. The second is weakness. And the third is structural or mechanical abnormalities starting from the spine to the pelvis and to both lower extremities. So in order to understand the pathophysiology of limping or abnormal gait, we have first to know that the normal gait is composed of symmetrical, alternating, rhythmical motion that involves two phases, stance phase and swing phase. And the stance phase is longer. It represents about 60% of the gait cycle, while the swing phase represents only 40% of the gait cycle. The stance phase is the phase in which the foot is touching the ground. Whenever the foot is touching the ground by the heel or by the toes or by the whole foot, it is stance phase. And the swing phase is the phase in which the foot is not touching the ground. It swings in the air. And sometimes the type of gait is very helpful in identifying the etiology of the limb or the abnormality present during limping. This diagram shows the normal gait cycle. You can see that this is the long stance phase representing 60% of the gait cycle for the right lower limb represented in green here. And it is the phase in which the foot is touching the ground by any piece of it, starting from the heel strike to the mid stance to the two off at the end of the stance phase. And then starts the swing phase in which the foot is on the air of the right lower limb. And you can notice here that the gait cycle represents the gait for each lower limb separately. You have to analyze the gait cycle for each lower limb separately. Here we can see, we start to know something about some very famous abnormal forms of gait. Let's start with the antalgic gait here. Antalgic gait simply is the painful gait. Whenever there is any cause of pain in one extremity, this will lead to a very famous form of gait. All of us have experienced that at one time in our lives. So this will lead to trial to shorten the stance phase on the affected side. Whatever the cause of pain, there will be a trial to shorten the stance phase, and with the resultant increase in the swing phase in that on that side. And the typical causes of the antalgic gait are, of course, the presence of any trauma, contusions, or the presence of infection in that limb. The second also common type of abnormal gaits is the Trendelenburg gait. And in Trendelenburg gait, there will be a downward pelvic tilt away from the affected hip during the swing phase. Whenever you stand on the affected hip, or it is the stance phase of the affected hip, the pelvis will tilt to the opposite side as appears in this diagram. Here you can see it. And this is mainly due to weakness of the contralateral gluteus medius muscle, or the abductor, or the main abductor muscle here. If the abductor muscle is strong enough, there will not be no tilting of the pelvis. If the abductor muscle of the hip is affected or weak, there will be tilting of the pelvis to the opposite side during the stance phase of the affected side. And this can be seen also in some other conditions of the hip structural deformity, like in cases of DDH, or developmental dysplasia of the hip, cases of Burt's disease, or cases of slipped capital femoral epiphysis. And if it is present in a bilateral form, it will lead to what's known as waddling gait. So the common examples of the Trendelenburg gait, some very famous structural deformities, and the other is weakness of the abductor muscles, commonly seen in patients with neuromuscular disorders or myopathies. The third type of famous abnormal gait, it's what's known as steppage gait or equinus gait. It is the gait in which there will be inability to actively dorsiflex the foot to clear it from the ground in order for the gait to be smooth and to propagate efficiently. In this condition, there will be exaggerated hip and knee flexion during the swing phase of the gait in order to compensate for the weakness or the absence of dorsiflexion at the level of the ankle. And this gait can be seen in cases of neuromuscular conditions like cerebral palsy, in which there is often there will be tightness of the tendon Achilles with impairment of dorsiflexion of the ankle, and can be seen also in cases of paralysis of the lateral popliteal nerve supplying the anterior groove muscles of the leg that is responsible for the dorsiflexion of the ankle, or any condition associated with a fixed equinus deformity of the ankle. The fourth type is called a vaulting gait. In the vaulting gait, the condition is different from the steppage gait, of course, in which the knee is hyperextended and it is locked in extension at the end of the stance phase. So there will be inability to flex the knee smoothly. And so the child moves with an extended knee, and in order to do that, and his foot will be cleared off the ground, he needs to vault or rotate his limb or his lower extremity over in order to be able to take an efficient gait. It happens in case of leg length discrepancy, or if there is abnormal knee mobility, especially stiff knee and extension. The fifth type of famous abnormal gaits is what's known as a stooped gait. You can see it in patients with pelvic or lower abdominal painful conditions irritating the peritoneum, leading to the patient will lean forward, leading to flexion of the trunk on both lower limbs, increasing the hip flexion in order to relax the inflamed and irritated abdominal structures. Now it's very important to take a look at the different etiologies of limbing in children, and we do have two major factors that we can rely on in understanding these different etiologies. The first is the age, and if we categorize the age into three groups, one group, or the first group, from 1 to 4 years, the second group will be from 4 to 10 years, and the third group will be from 10 to 18 years. It's very helpful in order to suspect what are the causes or the common causes of abnormal limb. And the second very important factor is the presence or absence of pain. If there is pain, it is a painful limb or a painless limb. So, in the first group, from 1 to 4 years, the painful limb will be commonly the cause of, first, infections, any types of infection, either septic arthritis, osteomyelitis, cellulitis, synovitis, whatever in the muscles. The second cause of painful limb in this age group is the trauma, of course, a very common event in this age group. And the third cause is primary or metastatic neoplasm. These are the main etiologies that may cause a painful limb. The painless limb in this age group have also specific etiologies. The most important of them, the first and the most important this age group etiology is the DDH, developmental dysplasia of the hip. It's plastic hip. Once the child started to walk at the age of 1 year, around 1 year, if he had the DDH, there will be limping from the start of walking. The second etiology could be secondary to neuromuscular disease as cerebral palsy, muscular dystrophy, or myelomeningocele, for example. And the third etiology of painless limb in this age group is the lower limb length inequality. If there is lower limb length inequality, it's very important to stress on the fact that whenever there is a child limping in this age group from 1 to 4 years, you have to exclude the presence of DDH as a priority in the beginning, because in this age group also the pain may be absent or maybe sometimes difficult to express by the child in this age group. He will only limp. So it's very important to put in mind the diagnosis of DDH and to exclude it first. The second age group from 4 to 10 years in pediatric population, also the cause of painful limb will include infection, trauma, and primary or metastatic neoplasm. But here in this age group, we will add the inflammatory juvenile rheumatoid arthritis. Inflammatory conditions as juvenile rheumatoid arthritis or systemic lupus erythematosus start to appear in this early age group. And also we'll add some hematological disease as hemophilia, sickle cell anemia, or leukemia. Also, it's very important to remember the etiology that is mainly should be excluded in this age group, which is Legg-Calvé-Perthes disease, or better known as Perthes disease, which is a vascular necrosis of the proximal femoral epiphysis. It is the main cause of painful limping in this age group. Concerning the cause of painless limping, it is the same as the first age group. DDH presented for the first time after the age of 4 years. It is commonly seen as well. Neuromuscular disorders or leg length discrepancy or inequality. So in this age group from 4 to 10 years, whenever there is a child limping in this age group, we have to remember or we have to exclude that this patient is having a Perthes disease. This is the most important category and most common as well. In the third age group from 10 to 18 years, the causes of painless and painful limping are the same as previously in the previous age group from 4 to 10 years, but we have to consider very much the possibility of having what's known as the slipped capital or upper femoral epiphysis. In its acute form, it will be painful, it will lead to painful limping, and in its chronic form, it will lead to painless limping. So it is present in both categories. So in the age group from 11 to 18 years, it's mandatory to examine the hip and put in mind that the possibility of slipped capital or upper femoral epiphysis is present in this age group, either in the painful form or in the painless form of limping, and it should be excluded before searching for other etiologies. In addition to the previous main etiologies that's concerning the development of limping in the pediatric population, don't you ever forget to consider non-skeletal causes related to inflammations in the abdomen, like in the case of appendicitis, with psoas muscle irritation, will lead to very considerable limbing. And also in case of retroperitoneal neoplasm or infection, it could lead to limbing as well. As we have seen previously, there are many etiologies that may lead to limbing in children. So what's important is the way you are dealing with the patient, how to approach your specific diagnosis, accurate diagnosis, based on the information available from the history, thorough examination from the investigation, and then you can plan your way of management. Starting by the history, very important factors in the history. As the age, for example, we knew the importance of the age just in the differential diagnosis now. The etiologies can be categorized according to the age, from 1 to 3 years, 4 to 10 years or so, etc. So it's very important to know the important etiologies for each age in the pediatric population. Also for the sex, some problems occur more in females than males, like the DDH. The incidence of female to male is 6 to 1, and some conditions occur in the male more than the females, like case of Perthes disease, for example. Also about 6 or 4 to 6 to 1, male to female. It's very important also to analyze the onset of the condition, whether it happened acutely, as in cases of following trauma, for example, following acute infection, acute osteomyelitis, or there is a chronic or insidious onset, as in cases of chronic osteomyelitis, for example, or cases in which the destruction occurs gradually, as in case of Perthes disease. The presence or absence of pain and the analysis of this pain. If this pain is related to rest, to activity only, or it is present as well in the case of resting conditions, it's very important to know the duration, the intensity of the pain, and its location, whether it is referred to another areas or not. The presence or absence of history of trauma. And this condition, although it's very important to know the history, if there is a definite history of trauma, sometimes it is over-exaggerated from the parents. Sometimes the parents refer to any painful condition or any limbing in their children to the presence of trauma. And if you analyze that specifically, you will not find any history of non-trauma to them. Also, the association of the history with night pain, with arthralgia, with swelling, with morning stiffness or backache, some factors may give you a clue about the diagnosis, like these etiological factors are present, for example, in the inflammatory joint disease. Also, in the history, it's very important to do a systematic review of presence of a recent illness, like the recent urinary tract infection, for example, which is a source of septic focus for the presence of infection. The weight loss or anorexia, which could give attention to the etiology of the presence of metastatic bone disease or the presence of bone neoplasm. Fever or chills for cases of infection, for example, osteomyelitis or septic arthritis. The presence of unexplained rash or bruising, which is associated with the certain blood diseases, can be the key for your diagnosis of this presence complaint of limbing. Also, the presence or absence of voiding problems. If the child is old enough and has a voiding problem, this may lead to the diagnosis of certain neuromuscular disorders in which the child is lacking control over his sphincters. Concerning the past history, the presence of some chronic illness and the medical conditions or past medical conditions for the child can lead to lowered immunity, which may predispose the patient to have grave infections as septic arthritis or osteomyelitis. Also, the use of some drugs can affect the immunity as steroids, and also the steroids are known for to predispose for development of avascular necrosis in areas near the joint, which may lead to limping in children. Developmental history is very important to know how the child was being nursed while he was in the neonatal period. Sometimes nursing the children in full extension of the lower limbs may predispose the patient to have a developmental dysplasia of the hip. The nutritional condition also is important. Sometimes lack of some important vitamins as vitamin D may lead to deformities in the bone with resultant some types of limping. And the vaccination of the patient. Sometimes the site of the vaccination could develop or lead to hematoma formation and further, and after that will lead to calcified hematoma in major muscle like the gluteus maximus or in the lower limbs. That may lead to limping in children. Sometimes it's very important to know if this child received or the onset started after a vaccination of the child. Concerning the family history, it's very important to take if there is a positive family history in case of like hemoglobinopathies or neuromuscular disorders, or in case of developmental dysplasia of the hip, because they all have a familial history or tend to spread in families. In social history, some diseases are said to be related to poorer communities. Like in cases of Perthes disease, it is well known to spread in communities with poorer background than other diseases. Then we can go for examining the patient. First, by general inspection, we should see the posture of the patient, and if there is major deformity appearing in the lower limbs, or if there is any major deformity in the back of the patient, like cases of scoliosis or kyphoscoliosis, for example, and then we'll have to inspect the gait itself, how the patient is walking in front of you. And as we said before, the importance of sometimes of examining the gait. Some abnormal gaits are very famous, and it can give you a clue about the diagnosis immediately from the type of the gait itself. Then go for examining the vital signs and anthropometric measurements for any to exclude any form of skeletal dysplasias or abnormality in the span of the patient to the height of him. Then, by systematic musculoskeletal examination of the lower limbs and the back, in order to know if there is any disparity, if there is any gross deformity of the bone first, if any disparity at the level of the range of motion of one joint than the other, the ankle than the other ankle of the other side, the knee as well, and the both hips, or there is a gross abnormality of the back, as we said before, the kyphoscoliosis or scoliosis. So the presence or absence of any tendon tightness, for example, at the level of the Achilles tendon. Sometimes there is a congenital short Achilles tendon may lead to steppage gait or equinus gait. And after finishing the musculoskeletal examination, you should go for neurological examination. Neurological examination in order to know if there is spasticity, for example, in the lower limbs. Spasticity in one limb or both limbs will lead to limping, of course, and is commonly present in cases of like cerebral palsy. And in spastic conditions, you will have severe tightness of some of the tendons, like the tendon Achilles leading to equinus, sometimes the hamstring muscles leading to flexion deformity of the knee, or the adductors of the hip leading to very limited abduction of both hips. Also, neurological examination can give you an idea about the absence of movement, sometimes paralysis, complete flaccid paralysis of the foot, for example, cannot dorsiflex the foot in some children with myelomeningocele. Patients with myopathies sometimes cannot do a lot of movement and they have contractures of the muscles as well, and the presence of absence of sensations in certain areas of the foot or leg. And you should end your examination by evaluating the leg length. Evaluating the leg length can simply give you a clue about the diagnosis. The cause of limbing can be simply the leg length inequality or leg length discrepancy. You have to measure both limbs from the anterior superior leg spine to the medial malleus of each limb, and then compare the length together. Some laboratory tests are very important and can give you very clear idea about the etiology. To start with is simply the CBC can give you an idea about the presence or absence of anemia, thrombocytopenia or thrombocytosis, leukopenia or leukocytosis, and also the presence of elevated ESR or CRP in case of infectious conditions or inflammatory conditions in juvenile rheumatoid arthritis, for example. Blood culture in case of infection could be very helpful if you suspect severe infection. Also, sickle test can be done in case of sickle cell anemia, which can lead to painful limping. Coagulation test for the presence or absence of coagulopathies. Some immunological tests can be used, and they are specific if you are thinking of a case of inflammatory joint disease, as the rheumatoid factor anti-nuclear antibody test. Imaging studies in investigating the cause of limbing are very important. They can give you a very good idea. For example, in the plain X-ray can give you a very good idea about the presence or absence of a lot of conditions, including the hip conditions as the developmental dysplasia of the hip, Perthes disease, slip capital femoral epiphysis. All of these conditions are diagnosed solely by plain X-ray. Ultrasound can be very beneficial if you are looking for an effusion inside the joint, especially a concealed joint like the hip joint, to differentiate between the simple effusion or if you suspect septic arthritis or inflammatory effusion inside the joint or hemarthrosis, for example. The CT is important to detect some of the neoplasms in the bone or some benign painful conditions like the osteoma, for example. MRI is also very important for the case of neoplasm and bone scan as well in order to detect any neoplasm and its distant metastasis. One of the investigations that's important and can be done and give very good information about the underlying problem is the synovial fluid aspiration and examination. Examination for the appearance, for the white blood cell count, polymorph count, and some other features can differentiate between normal traumatic juvenile rheumatoid arthritis or the presence of septic arthritis in that specific joint, according to the criteria present for these four parameters. So it's a very beneficial tool if you have a joint that's inflamed, that's swollen, and with effusion. It can be a very strong diagnostic tool to diagnose the problem of this patient, whether it is traumatic or inflammatory or septic. Now, after we knew most of the etiologies then that can lead the child to limp and how to approach it through the history, the examination, and the investigation, it's very important to shed some light about the pitfalls while you are diagnosing a case of a limping child. First, it's very important to not to be misled by the parents' analysis of their child limping. The parents will always refer to their limping child as having a leg length discrepancy. they will always refer to that. So sometimes you have to ignore the parent's analysis of the complaint and search for the problem yourself through the systematic approach as we were talking about previously. And sometimes don't be misled by the patient himself. The patient's complaint, sometimes it will mislead you. For example, hip problems almost always will be referred to the knee and to be felt as a severe knee pain, and sometimes severe enough that the physicians will go for investigating the knee by X-rays, by MRI, and some rare conditions there have been knee arthroscopy has been done for patients because they insist on that the complaint is mainly in the knee. Don't you ever be misled by the patient's complaint, especially in case of you suspect hip problems. And concerning the complaints of pain, we should always remember that children below the age of 5 years will limp without complaining. Children above 5 years will complain and give a full details about the pain. So don't ignore that in children below the age of 5 years, and do examine very carefully. You will find that the range of motion for joints, and sometimes or with just palpation or examination of the limb thoroughly, you can elicit pain in these children. So in some causes of limb due to skeletal abnormalities or musculoskeletal abnormalities, for example, if there is a problem at the level of the joint, there will be the range of motion is very important, so it will be detected by the physical examination. In case of bone deformity, it will be detected simply by X-ray, plain X-ray. In case of hip pain, for example, or pain in the hip, there will be an antalgic gait or an abductor lurch if it is in the hip. In case of the problem in the control, in the case of neuromuscular disorders, examine the upper limb. Sometimes the condition is taking the whole body, so examination of the upper limb will be the key for your diagnosis. In most of the cases of child limping due to skeletal causes, and these causes are very obvious, like what we are seeing here in these photos of the patient with very obvious severe clubfoot or genovarum, genovalgum, deformities in the lower limbs. These are very obvious causes of deformities. Also, the back problems like scoliosis and kyphosis are very obvious for the patient, for the parents, and for everyone. Even the problems in the foot will be very obvious in the whole lower limb and in the back. So in these conditions, the diagnosis will be very easy for as an etiology of limping. When you look at the etiologies of the limping child, you may think that there are too much to cover. And actually there are too many etiologies for the child to limp. Some of them are skeletal and some of them are non-skeletal, like the blood disease, for example. And in this condition, on this case, you have to look for the clues. For example, you may find very simple clues. For example, in patients with blood disease, there will be certain bruising or rash or unexplained rash all over the body. If there are fever, for example, you are thinking of infection, whatever it is, osteomyelitis or septic arthritis, for example, in a certain joint, and it's easy to go for this diagnosis. Neoplasm, you will find anorexia or loss of weight. So there are too much to cover, but you can plan your diagnosis based on excluding a lot of major problems. And some of the problems are very obvious, as the photos we have just seen for deformities of the lower limb or deformities of the back. If there are deformities around the foot or around the knee or in the back, it will be very obvious. But some conditions are affecting the lower limb are not very much obvious, especially cases affecting the hip or conditions affecting the hip. So you have to think of the best bits of the concealed problems or the unobvious problems that may affect the lower limb. These are mainly problems inside the hip. And if you detect it and correlate it with the age, you will find your diagnosis easily. In the age group from 3 to 6 years, it's very important also to think or remember these two etiologies, the transient synovitis and septic arthritis of the hip. Usually following a flu or tonsillitis, the patient will start to limp and it's a painful limping, and by time he will lose his ability to walk. In case of transient synovitis, the child will refuse to walk and the movement of the hip will start to be very painful. Sometimes he will have fever and he will show on the CBC there will be a moderately elevated white cell count. It will last only for a few days and disappears even without treatment. In case of septic arthritis, while in case of septic arthritis, child will refuse to walk. Movement of the hip is very painful. Mostly he will have fever. There will be strongly elevated white cell count. The patient will be progressively sicker and there will be progressive joint destruction in case of septic arthritis. In septic arthritis, the destruction of the joint surface will come from both the bacteria itself and the defensive mechanism. Both will will release enzymes leading to destruction of the articular cartilage, and there will be irreversible joint damage in a very short period. So in the worst case scenario in case of septic arthritis is you have destruction of the articular cartilage, destruction of the femoral head, and destruction sometimes, destruction and absorption of the femoral neck with a totally deformed joint. So in case of septic arthritis, you have to be a little bit aggressive in your approach. First, you have to kill the bacteria by giving strong antibiotics. Then eliminate the white blood cells, as it is a cause of destruction as well, by incision and drainage of the sepsis from the joint. And you should not delay this. You have a 48-hour window before the destruction of the articular cartilage. So sometimes it is difficult to differentiate between the transient synovitis and septic arthritis, and it's very important to differentiate between them because the approach of management is completely different. In transient synovitis, you will wait and see. You will wait for the improvement of the condition spontaneously, and in septic arthritis, you have to interfere as soon as possible. So how to tell the difference? There are 4 predictors that can tell you the difference between transient synovitis and septic arthritis. History of fever. Usually the fever of the septic arthritis will be severe, will be highly elevated temperature, above 38.5, 39. while it is in the transient synovitis, very mild fever if present. Most of the time it is not present. The patient will completely refuse to weigh beer in case of septic arthritis. ESR is more than 40 millimeter in the first hour, and white blood cell count is more than 12,000. And if you are in doubt, if these parameters are equivocal, review this patient at 12 hours, and if he had the same equivocal parameters, do incise and drain. Even if he is transient synovitis, nothing harmful will happen to him, while if he is septic arthritis, he will lose a lot if you did not incise and drain the pus from the joint. In the age category from 4 to 10 years, the painful limping in children, you should ask for an X-ray of the pelvis, of the hip, because of this very famous condition occurring in this age group, which is called the Perthes disease. You can notice that on this side, on the left side of this left hip, you will find there is a collapse in the proximal femoral epiphysis. While it is normal on the other side, we have here a collapse due to a vascular necrosis of the proximal femoral epiphysis. At the start there will be collapse, then there will be a permanent deformity of the joint. And this collapse at first will be associated also on the lateral view, on the lateral view. You can see severe collapse of the proximal femoral epiphysis in comparison to the other right normal side. After this, at the beginning, there will be inflammation of the joint with effusion and limited motion. After a while, with the healing process, there will be a deformity in the hip joint, which is variable according to the degree of affection of the proximal femoral epiphysis. So it's very important to remember from 4 to 10 years, child is limping, especially if the limb is painful, you should look for the diagnosis of Perthes disease, which is a vascular necrosis of the proximal femoral epiphysis. In the age group from 10 to 18 years, one of the most important etiologies of the child to limp in this age group is to have a slipped capital femoral epiphysis. What we mean by slipped capital femoral epiphysis is that the femoral epiphysis will move downwards. This is the normal side. This side is the affected side. It will move downwards and posteriorly or backwards at the level of the growth plate or the physis of the neck of the femur. So the upper femoral epiphysis will leave its place and displace inferiorly and posteriorly relative to the neck of the femur, leading to one of the most common causes or etiologies of limping in this age group. So in the worst case scenario in case of septic arthritis is you have destruction of the articular cartilage, destruction of the femoral head, and destruction sometimes, destruction and absorption of the femoral neck with a totally deformed joint. So in summary, always try to remember the main etiologies that may lead to a child to limp. Very important to be systematic in your approach to reach accurate diagnosis. And while you are doing that, don't be misled by the parents or sometimes the patient's own complaint. And always think of the common concealed conditions, especially when it is concerning the hip problems. Always think of the common conditions like DDH in age group from 1 to 4 years, Perthes disease from 4 to 10 years, and slipped capital femoral epiphysis from 11 to 18 years. Thank you very much.